Morning, Mr. Chairman, panelists, my colleagues. I'm very happy to share with you this very interesting case. So this is my disclosures. My case is a 65-year-old male patient, hypertensive, heavy smoker, not diabetic, not known to have any other chronic diseases. He was admitted in other center with acute STEMI about 12 hours before referral to our center for possible pharmacoinvasive PCI. He received thrombolytic therapy on admission, and he was treated with aspirin, dual antiplatelet therapy, beta blockers, ACE, and statins. Coronary angiography was performed at our center via the right femoral access, Judkins catheters. This case was started by one of my younger colleagues, and this is images of the diagnostic angio. He has ectatic coronary arteries with only one significant lesion in this mid-LAD, the culprit and the only one significant. The assay also was ectatic with slow flow, but without significant disease. So my colleague, he attempted to do a PCI for this LAD, and this is the first image after with using EBU for guiding catheter. So I was called at this stage to see what is happening with this patient. It's not a so lucky time to be in this situation. So the first thing which I did, I took more friendly, I can say, guiding with Judkins lift 4, and I did this maneuver, which showed me that exactly that I am dealing with an extensive left main antegrade and retrograde dissection, mimicking here occlusion of the left main and the branches, and this antegrade and retrograde in the entire ascending aorta. So my first attempt was to cannulate the true lumen, and this was the first after a few minutes. It's a usual BMW coronary wire. I was able to cannulate the true lumen of the LAD, and actually I can see again the left system. At this stage, my patient was having chest pain and with a little bit hypotensive, systolic blood pressure down to about 80 millimeter mercury. So after that, I implanted this NOR 0, 3.5 by 30 stent from the ostial left main to the LAD. That was the first maneuver. After that, the patient started to stabilize. There's less chest pain. His blood pressure starting again to be around the normal 110. So, and when I saw that my patient is stable, so after that I continued the procedure, stenting this mid-LAD, which was a very easy lesion. We fixed this lesion of the LAD. This was my first cranial view. And at this view, I observed here that I have probably it's the roof of left main, the site of entry of the dissection. And that's, for me, it's easy to explain because this is the site where usually the ABU guiding, hitting, or exerting the force against the roof of the left main for backup. So at this time, I tried to seal the site of or the decrease, minimize the extravasation by deploying another stent in the left main. It was a 4/0 by 8 stent, also a Zion stent, in the left main. And after that, this is my final outcome. It was, for me, an excellent outcome. The patient at this time we performed an echo in the cath lab. There was no pericardial effusion. Ejection fraction was around 40, 45. There was also nothing specific in the aorta. So we finished the procedure at this stage. And a few hours to see what happened with this patient, or to try to explain, about 8 hours later, we performed an angio-CT, which showed us a relatively small intramural hematoma in the posterior wall of the aorta. Our stents from the left main to the LAD were in a perfect position. So our patient was followed for 48 hours, and everything was okay, and 48 hours was discharged home. This patient, we asked the patient to come back to repeat angio to see what happened with the stent, but he was asymptomatic and he refused to repeat angio. This case was done around actually 1.5 years. And since 1.5 years, we are following this patient outpatient clinic every 3 months, and he's still refusing angio to repeat angio until this moment. And he's still asymptomatic.
I can imagine.
So I can conclude it's heterogenic aortic dissection during coronary angiography or percutaneous coronary intervention is a rare but a catastrophic and potential fatal complication. The reported incidence of this complication in the literature is 0.02 up to 0.07%. Dissection of the right coronary artery occurs more frequent than the left main dissection. Some of the predisposing factors for this complication are the type of catheter or guiding left main disease, hypertension, unicuspid or bicuspid aortic valve, Marfan syndrome, and acute MI. There is no guidelines or pre-established treatment for this case because most of the cases published in the literature were treated by stenting, but some by surgery according to the patient's coronary anatomy and hemodynamic possibility. The recognition and decision of the strategy of treatment are essential for the success of the treatment. Thank you so much for your attention.
Did you remember and check your heart rate when you see the first picture?
Over 120, maybe over 150. Because
Okay,
I was during the round and I was called to see what was happening in the cath lab, and that was my first angio.
Okay. Questions, comments? This is, as you said, and I guess it's very well that you really to mention that there is some predictors, but it is quite rare
Yes.
and actually and I guess that what you did, and it's quite interesting thing, and what you showed us, and you did two steps, which is for me it's very important. First of all, you did a small angio, and then you see what's happening with hematoma inside the wall, in the aortic wall, and in the aortic lumen, and then you change actually the guiding catheter from extra support to more soft and more gentle, like GL Judkins left. And I think it is very, very smart was, and you also to find a right lumen, and then you fix the coronary. And I don't know exactly what we've seen, and this is right. I also we sometimes try to find something in literature. There's only anecdotal cases how we can see and how we can deal with aortic dissections. But at least what we've seen, if you have hemodynamic stability, you should not to send to surgery, because then the result is usually worse than if you do this conservative. Please. Questions and comments, and this is a it's very, I'd say, ugly pictures what we are seeing when it is, and it's not easy. But yes, please. Yeah.
Thank you. I didn't see which wire did you use for
BMW. Yes. Usual BMW, it takes just a few minutes, 3 to 5 minutes to find the true lumen.
And did you did you have any difficulties passing through the right lumen in the left main and the LAD?
By the wire?
By the wire, yes.
No, but it took around a few minutes, 3 to 5 minutes to find the true lumen.
In our hospital, we had this probably the same case but we lost the wire and we couldn't cannulate again. So
I think it is really depends on from where dissection coming.
It
And
was
in these
cut from
particular
left main.
cases, you were lucky because
Yeah.
Yes.
the lumen was open and origin of left main was open. And this is, but this is, of course, this is a point. If you have the situation
we had the
yeah.
situation where dissection came from mid shaft of left main. It was a small flap, but it extended rapidly, and patient got
And what
into
you
shock.
did? How you managed this?
I wasn't performing that case, but
No, that's for sure. It's always our colleagues doing cases, which is not. That is for sure. That's like this is I know from so many years, and people started. Of course, it's not my case. My colleague did
No,
that one, but you know.
I wasn't back then. I wasn't experienced.
No. Yeah, but how you manage it? Yeah,
We couldn't cannulate. We lost left main. I don't know. In a seconds, we lost left main. So patient died in maybe
yeah, it's happening,
yes, in maybe
unfortunately.
10 to 15 minutes, and that was dramatically.
I think I was lucky to find the left main fast. The patient was started to have hypotension and chest pain, but it wasn't a long period, just 3 to 5 minutes. And also a trick was to push a little bit the guiding to be sure that it's a left main. I am in a true lumen. Once I found that it's the true lumen, very fast stent from the ostial left main, and
Just building
after
on what
that it was, yes.
building on what you're saying though, you have to be very careful because things are very, very fragile in there, and I've seen cases where the wire can go in and out of the true lumen, and when the wire is distally, it enters the true lumen. So I usually, most people would perhaps agree that perform IVUS if you have it available, because often you think you're in the true lumen, you get the IVUS catheter out, and you go, oh, I'm actually, the proximal bit is all in the false lumen, and I've re-entered into the true lumen more distally, which often can happen because the vessel tapers. So there's only one place the wire can go is in the true lumen. So, if you've got availability of IVUS, I don't know if you do in your centre, I would probably encourage you to IVUS, because I've seen it where people have stented from false lumen into true lumen, and then, once the stent's in, that's it, it's game over, So it's just because you could do this 100 times, half the time you may end up in the false lumen, You won't do it 100
Hopefully,
times.
you will not deal 100 times with their cases
I
like
think-
this one. Otherwise, you should
I
leave
think
your job. I'd say.
Yeah, you know what I mean, but-
No, but you are right. But you had the comment.
Yeah.
Yeah.
It was the same thing.
Yeah.
I was proposing that before committing for the stent, once you have established that there is a TIMI 3 or TIMI 2 flow, you should do an IVUS and have a look whether you are in the true lumen, and then commit for the stent.
I really support the usage of imaging in case if you are not in very big trouble. But in this particular, I am not against, and I completely agree. But in this particular case, you see that actually after the recast, there was a very good flow, and this is of course. But I agree.
Because it's so fragile in there, the wire could easily just go in and out of the true and false.
Yes, you are right.
I've seen it, and
Sometimes the change of guiding catheter, like this dissection was by Judkins diagnostic catheter. So we took a EBU in this case. Change of catheter, like it was a dissection by the diagnostic Judkins catheter.
No, sure, it was by the ABU guiding. But my colleague is starting to have, to cannulate the left main, and that was first angio. And at the end of the diagnostic procedure, I repeated the angio views. There is no dissection. So it was surely by the ABU.